And if you look at the post-op film after the Miller procedure, you see that the talometatarsal angle is completely normalized and the sinus tarsi has opened up with no hindfoot procedure at all. So this is a pretty good operation for mild hindfoot valgus. It's just not very good for dramatic hindfoot valgus. And you look at the AP view, you see that the talonavicular coverage angle is back to normal. The talus and the first metatarsal line up as exactly as we'd hoped that they would. Medial column arthrodesis can be combined with other procedures, such as this patient with a much more dramatic talonavicular subluxation. In this case, a lateral column lengthening combined with a medial column stabilization brings about all the corrected change that's needed. In this case, the lateral column, the Miller procedure is done here, and the lateral column lengthening is done here on the calcaneal side, and that corrects the much more severely abducted foot. Calcaneal osteotomy has gotten a lot of press. It's something that was described a long time ago by Gleich. Koutsaganis had the most recent significant article on the subject, and even that is 30 years old. But basically with this operation, you cut the heel and you move it over until it's underneath the axis of the talus, thereby taking away the abnormal torques going on in the hindfoot. And his review demonstrated, one, it doesn't work without lengthening the heel cord, and two, that it's not enough for severe deformity. Now, he didn't obviously have CT scans in those days, so he couldn't tell if these joints were subluxed, but even he was able to observe that if you can't correct the alignment, then the operation doesn't work. So this operation works for patients with mild disease, as in this case. You can't really see the subtalar joint, it's subluxed a moderate amount. But post-operatively, after doing the medial column stabilization and after moving the heel over, the sinus tarsi opens up without a lateral column lengthening. You can see now a good lateral of the ankle and a good lateral of the subtalar joint. So lateral column lengthening is an alternative to triple arthrodesis for the patients who are more severe than either of these groups. It can be done through the anterior process or the calcaneal cuboid joint. It's done, as you know, by taking a large block of tricortical bone and cutting the calcaneus and fitting it in. This is a patient that Dr. Hansen did when I was a fellow back in 1987. This was a young person with a very flat foot. And if you look at this person's CT scan, you can see that even though it's a young person in her teens, he already has invasion of the calcaneus into the underside of the fibula. So this is not going to be something that's going to get better on its own by any non-operative means. You can see that the calcaneus is already impinging, and after the correction with the lateral column lengthening, the similar CT scan shows that talus now completely on top of the calcaneus and that fibular space completely opened up so that there's no longer any impingement. That's just a tendon Achilles lengthening and a lateral column lengthening through the body. As I said, this can be done through the calcaneus or through the calcaneal cuboid joint. It's all a matter of bias and what the patient has. For example, if the patient is like this one, here's a CT scan in the transverse plane showing substantial erosion and subluxation of the calcaneal cuboid joint. It makes sense to do that lateral column lengthening through the calcaneal cuboid joint rather than lengthening through the calcaneus and putting more pressure on an already arthritic joint. And this is what that arthritic joint looks like. So here's the graft. This whole area in here is graft, about 1.5 centimeters long. And you can see that here's the pre-op with talonavicular joint completely uncovered, and after just this 1 centimeter block, the talonavicular joint has restored its almost normal position. Similarly, on the lateral view, where there's a big sag in the talonavicular joint here, it's completely restored a normal first metatarsal angle on the post-op. And clinically, the foot goes from a pancake-like appearance on your left to a relatively normal arch on your right immediately after the surgery. So here's just a little clip to show how the lateral column lengthening works. This was put together by one of our chief residents a year ago. This is a cadaver foot in which we have created an anterior process osteotomy here. And I'll just clip it and kind of talk my way through it as it goes. There's the calcaneus, the cuboid, the navicular, the talus, and the tibia and the fibula. Looking at it from behind and from the medial side. Now we're going to fix the talus to the calcaneus to see what movements Chopard's joint does with the lateral column lengthening. So So now we're inserting a red block of bone. You can see that the navicular moves up and over on the talus. And for frame of reference here, we fix the talus. The tibia moves and the hindfoot moves all around the talus. So really the talus would move from a plantar flexion to a dorsiflex position, but we fix the talus. Now we've unfixed the subtalar joint. We're going to do the same thing. Taking it back out, you can see that there's a lot more motion in the subtalar joint, but most of the motion is through the midfoot. There's a dramatic movement of the talonavicular joint. And finally, we're going to look at it from the top and take away the tibia. Look at how the whole forefoot pivots around the talonavicular joint. So this is a very powerful surgical tool for correcting all three planes of the deformity. And this is a patient who had a lateral column lengthening and went from a very, very pancake-like foot to a relatively normal arch. And here's another patient who shows this used to be his good foot, and this was his bad foot. And this is nearly completely restored with just a tendo-Achilles lengthening and lateral column lengthening and nothing else. And this is just a 13-year-old who happens to be 6'6" and is already getting some interest from NBA scouts. Finally, the last osteotomy that can be done before going to a triple arthrodesis is combining the two, the lateral column and the glyc osteotomy. These are some pictures Art Manoli sent me, as this is his primary procedure. You can see that this is also a very powerful tool. It's a little bit of a tendency to overcorrect the hindfoot pitch, but is otherwise a very effective tool as well. And this is a patient who's had a correction on this side and not had a correction on that side. You can see that the motion is nearly identical even after this fairly substantial osteotomy. So these operations don't interfere with joint motion at all. Finally, if the patient is just too flat for anything, a triple arthrodesis remains an option. This also may be an option for the so-called tight floor flat foot. So here's a patient laying on the table. You can see the patella is indicated by this red arrow pointing straight up at the ceiling, and the foot's rotated out about 45 degrees. This is quite dramatic subluxation, and not likely to really be corrected by any of the lesser procedures. If you look at this patient's radiographs, you can see that talometatarsal angle doesn't even hit the navicular, never mind the first metatarsal. This is a completely subluxed foot. And in the lateral view, you can see that the foot is quite literally falling off the end of the talus. So for these patients, I think the only good opportunity is to get that sinus tarsi open back up and fuse the three triple joints, or do a triple arthrodesis. This is a very effective tool. You can see from the clinical photos that the foot is now in line with the leg, if I get my arrow to work. So here's the patella. The foot's now completely aligned with it as opposed to this 45-degree angle it was making preoperatively. So the surgical options include soft tissue procedures, medial column procedures, lateral column procedures, osteotomy, and fusion. And there's a lot we still don't know, but it seems that there's a shape of a foot that's common that predicates these patients to have pain. The flat foot's not a disease. It's some kind of common endpoint for a variety of subluxations and soft tissue problems. A tight heel cord is almost certainly part of the complex in the vast majority, and both subluxation of the joints and intrinsic shapes of the bones contribute. Treatment really should include balancing the soft tissues and restoring the normal relationships of the bones. So in answer to the patient's questions, is this genetic? There seems to be a little bit more of a tendency to occur in families, but no one has really identified a genetic link. Are there exercises I can do to prevent surgery? The only exercise I tell people to do is to stretch the heel cord, and the only data that shows that it works is very, very limited data. And probably by the time adults get to you with this flat foot deformity, the exercises aren't going to help them all that much. If they need to have surgery, they're going to be in the hospital a variable amount of time, from 1 to 3 nights, based on how many of these procedures they need. They need to be on crutches 6 to 10 weeks. They need to wear a cast for between 2 weeks and 12 weeks, depending on the procedure done. And they need to be off work between 2 days and 2 weeks, depending on how much they like their work and how much they have to be on their feet. So thank you very much for your attention. I'd be happy to answer any questions. Dr. Hansen.
I occasionally get fooled by the fact that the patient has a congenital coalition under their flat foot. I'd be interested in what are the signs that you have that make you suspect that, how you evaluate for it, and how it changes your treatment.
So that's a great question, and obviously if you can be fooled by it, a lot of other people can be fooled more easily. The one thing that I do is do a weight-bearing CT scan on every patient who I'm considering surgical intervention. And as you know, a tarsal coalition is much easier to pick up on CT scan, but still on clinical exam, you're going to maybe, if you're lucky, notice that there's limited subtalar motion and beaking of the talonavicular joint. I guess I would turn the question around and ask you, what do you do if you find out that there is tarsal coalition? And there, as you know, there was a recent forum on the AOFAS website asking that exact question. I'd be curious to have your thoughts on what the best approach is.
Well, of course, by definition, the coalition means the talus and the calcaneus are fixed in their sometimes abnormal position. So my feeling is you just have to remove the coalition. And I usually go between the posterior tibial tendon and the flexor hallucis on the medial side, being careful of, of course, the neurovascular bundle, and remove it, and then go through the same process that you've already described.
I think that's good. And you notice that when I showed the video clip of the cadaver foot with the screws in it, that we first fixed the subtalar joint before doing the lateral column lengthening. And one reason we did that is because we had a patient at that time that had a tarsal coalition and needed the lateral column lengthening. And that's exactly what we did. We excised the tarsal coalition, went on and corrected the foot as if it weren't there in the first place. But it certainly does make things a lot more complicated.
Dr. Sangeorzan, patients often ask about return to avocational activities, everything from treadmill, exercise bike, to skiing and running and other activities. I was just wondering what you tell patients in terms of correcting their symptomatic flat foot.
So that's a great question. A lot of the patients could use the exercise. A large percentage of these patients are overweight and sedentary because they've been restricting their activities for some time. Typically their symptoms occur a year or so before they get to us for surgery. So we do want to get them back to as an active a lifestyle as possible. And with all of these procedures, up to the triple arthrodesis, we don't impair any function of the foot. We leave all the major functions of the foot intact so that they can go back to skiing, tennis, hiking, whatever they want to do. But it is a big operation, and I tell them up front that it takes longer to recover from this type of surgery than it does from heart surgery. It'll take them 4 months until they're back into a regular shoe, doing normal activities of daily living, and then probably up to 6 months before they can start doing recreational activities. And for some patients, it takes up to a year before they can go back to running and high-end activities.
Okay. What do you tell parents that ask you when they should bring in their children to be evaluated for treatment?
It's a very good question. The question is, what do you tell parents whose children have flat feet? And part of it depends on why the question is asked. The old literature, at least as old when I was a resident in the mid to late 80s, indicated that flat feet in children is not a problem and could easily be ignored. But I think if the children are complaining of discomfort, that's a very different category of patients who just have flat feet. As you know from Staley's article, all children have flat feet when they're young. It's only the patients who get up to be around 8 years to 12 years of age who start complaining of the same type of flat foot problems that adults have. So I'd say as early as 6 to 8 years old, if the child says they hurt, they should be evaluated. If they're just flat and the patient's running and keeping up with his peers, I wouldn't worry about it during the childhood years.
Dr. Sangeorzan, in patients who have bilateral disease, but one side is more symptomatic than the other, is there anything that can be done surgically to prevent the progression of the disease on